Each presentation is 4 minutes. Please make sure that your presentation is exactly as per time. There will be negative marks for shooting on time. And we will present and just maybe one question after each presentation so that we can finish on time. Huh?
Right.
No questions. Okay. If we have time in the end, we will see questions. We'll all present and then move on to the next presentation. Okay? So all presenters to go to this podium, please. So first talk is microkeratome versus femtosecond laser assisted SALC, a randomized controlled trial. The chief and presenting author is Mrinalini Singh.
A very good afternoon to everyone. I'm Dr. Mrinalini Singh, and I'll be presenting my work on a randomized controlled trial between microkeratome assisted and femtosecond laser assisted superficial anterior lamellar keratoplasty. Various causes of superficial superficial corneal opacities, they lead to 1.5 to 2 million cases of monocular blindness per year globally. And various surgical options are available besides lamellar keratoplasty. But our RCT was for the first time aimed to compare the two surgical techniques, that is microkeratome versus femtosecond laser assisted SALC. It was a prospective interventional single center trial, randomized controlled trial with a sample size of 72 eyes, and it was aimed to compare the various outcomes between microkeratome and femtosecond laser assisted SALC. Visual acuity was our primary outcome. We included superficial opacities within superficial 200 microns of cornea and excluded those deeper than 200 microns. Thorough preoperative evaluation was done. The 72 eyes were randomized with a simple randomization into two arms. The study arm had 36 eyes which underwent femtosecond laser assisted SALC, and the control arm underwent microkeratome assisted SALC. We followed up our patients for 6 months. Femtosecond laser assisted SALC was carried out in femtosecond OT, where pre-fed data was fed in the Visumax femtosecond workstation. The donor cornea was mounted on an artificial chamber, and epithelial scraping was done. It was followed by the removal of the lenticule, and similarly recipient cornea was prepared using femtosecond laser. And recipient bed was prepared. The donor lenticule was mounted on the recipient bed and was secured with glue. This was followed by placing a bandage contact lens for around 24 hours. The microkeratome assisted SALC was similarly carried out in our main OT on Gibor's automated microkeratome, and donor and recipient lenticule of similar thickness and diameter were created, and donor lenticule was secured on recipient bed with glue, followed by BCL. Our results showed insignificant differences in between the BCVA in the two groups after a period of about 6 months. And similar insignificant differences were found in various secondary outcomes like contrast sensitivity, K readings, corneal thickness, corneal aberrations, and even the development of complications. So we could conclude finally that microkeratome assisted SALC is non-inferior to femtosecond laser assisted SALC for the treatment of superficial corneal opacities. This alleviates the apprehensions of the surgeon in choosing between the two techniques, and the surgeon can make a choice as per their expertise and resources. Thank you.
Thank you. Can the next presenter come on?
Yes, I'm here. Ready. Can I start now?
Yes, please.
Okay. Thank you very much, sir. So I'm going to discuss few cases of intrauterine familiar exudative retinopathy as a presenting feature of congenital corneal opacity. So FEVR, as we know it as, is an abnormal case of retinal angiogenesis leading to incomplete vascularization of the peripheral retina and ischemia. How is it different from a ROP? Is because it can be seen in children who are term as well, and they do not give any history of oxygen exposure and blood transfusion, other risk factors of ROP. And it can be autosomal dominant, recessive, X-linked, and so far 14 genes have been known. and primarily it is a retinal disorder, and anterior segment changes are not well described in literature. So our aim is to describe a phenotype of FEVR with distinct anterior chamber findings. It was a comprehensive ophthalmic examination of children who presented to us with bilateral or unilateral corneal opacity, or on whom we did AIOS2025 and UBM imaging along with fundus changes of family members as a screening was conducted, and genetic data was collected as much as possible. So this is a case of a child with bilateral central corneal opacity with peripheral sparing, who belonged to an orphanage. That's why parents could not be screened, and he had microcephaly. Otherwise, all other features like tortuology, etc., was negative. Here we can see on AIOS2025 as well as UBM, there is on AIOS2025 there is a thick hyperreflective membrane suggestive of the iris plastered to the endothelium. Along with that, there is increased corneal thickness, and the UBM also shows here that there is some kind of calcified material stuck, most likely calcified cataract, and something else beyond that, some kind of tags which are going into the anterior vitreous cavity. Ultrasound shows this falciform fold, along with that retinal detachment in the right eye and multiple vitreous echoes in the left eye. So we wanted to go ahead with genetic testing, where we could find there was LRP5 mutation positive, suggestive of FEVR, and this child family, as I told, could not be screened. Coming to the second case, a unilateral case of a child who was only 5 months old. She also had the similar peculiar feature of increased corneal thickness with the iris plastered, along with that tags going into the anterior vitreous cavity, with ultrasound showing similar findings. Here on family screening in the mother and the older sister, we could see some subtle changes of FEVR with temporal avascular retina and dichotomous branching, but genetics in this case was suggestive of FBN1. Similarly, this is the third case where we are seeing the similar findings, and genetics in this particular case was not positive, and I'm quickly going through these cases. This child had similar peculiar findings, and on family screening we could see the mother having this peripheral retinal changes along with exudation suggestive of FEVR. And another case with consanguinity, and there was presence of tractional bands again, and the father who had a full-fledged FEVR grade 2, type 2, and the child could not be called for further UBM testing. And this is another case who had LRP5 mutation positive with same findings as the previous cases, and mother was not available for screening, but the father had low vision since birth, suggestive of FEVR. So we had 6 patients, out of which 2 males and 4 females were present, and 83% of the cases were less than 1 year of age, and 5 cases were bilateral, and 4 out of 6 cases had FEVR changes in either of the family members, the parents or the family members. So the key learning points in this case teaches us that unilateral or bilateral corneal opacity with shallow anterior chamber and thick corneal pachymetry in the absence of prematurity or oxygen delivery at birth, we must think of ruling FEVR in such cases, and you must do a detailed phenotypic examination along with ultrasonography and familial screening as well, and genetic screening if possible. Thank you.
Thank you. Next presenter, Dr. Priyanka Pantola. Are you here? Fourth presentation, Dr. Purva Kher. Not here. Fifth presenter, Sucheta Kaul.
Good afternoon, everyone. I'm Dr. Sucheta Kaul Gugnani, and I'll be presenting my study on allogenic simple limbal epithelial transplantation in chronic vernal keratoconjunctivitis. So as we all know, VKC is a bilateral atopic condition usually having recurrent episodes, and these recurrent episodes can lead to conjunctivalization of the cornea, further leading to visual impairment. This visual impairment because of bilateral limbal stem cell deficiency can be treated with limbal stem cell transplantation, usually in the form of allogenic slit. So our objective was to assess the outcomes of performing allogenic slit in these patients of bilateral total LSCD secondary to chronic VKC. In the methodology, it was a retrospective observational study which took place between September 2019 and August 2023. We included 5 eyes of 3 patients with chronic VKC. We collected the data on various aspects, including the treatment history. Imaging characteristics were noted in the form of AIOS2025-Poster and slit lamp imaging. We started all the patients on medical management with sodium chromoglycate, tacrolimus, and topical steroids in tapering dose. In the surgical management, allogenic slit was performed where the limbal stem cells were harvested by SNP biopsy from a cadaveric donor. Out of the 6 eyes, owing to the various intensities, total limbal stem cell deficiency was noted in 5 eyes, which were included in this study. These are the donor details of the same. So the first case had the preoperative BCVA of 2200 in the right eye and that of counting fingers in the left eye. There was dense fibrovascular proliferation seen as in the images above. AIOS2025 showed a very irregular epithelium and dense pannus formation, but a relatively clear underlying stroma. Similar characteristics were seen in the second case as well, where the right eye BCVA was counting fingers and that of the left eye was hand movements. The third case had a varying presentation in both the eyes, so we only took the right eye for our study, which had a worse presentation of vision only counting fingers. Post-operatively, all the patients were started on topical steroids, antibiotics, tacrolimus, sodium chromoglycate, as well as oral steroids. What should be noted is we also started the patients on tablet cyclosporin or methotrexate as systemic immunosuppression. These are the pre and post-operative images in the top and the bottom row respectively, where we can see the drastic improvement. Also seen with the AIOS2025 of all the 5 eyes, where the epithelium is regularized with no further pannus. Visual acuity assessment shows remarkable improvement in all the eyes. We had seen a little fall in the visual acuity of one of the cases because of failure of compliance to the medicines. So in a study by Dr. Basu et al., we noted that there was complete ocular surface epithelialization happening after 14 days of surgery. In a study by Vazirani et al., allergic conjunctivitis turned out to be the second major cause of bilateral LACD. In a study by Shanbag et al., positive results with allogenic slit was seen even with long-term follow-up. This was also noted with our study. Another study by Dr. Pragnya et al. Showed histopathological characteristics of chronic VKC in the form of epithelial downgrowth and leukocytic infiltration seen with the black arrows in the first picture. The solid cyst as seen in the second and the third sector. This was also seen with our patients as well. So in conclusion, chronic VKC can result in advanced bilateral limbal stem cell deficiency, and this may subsequently require surgery. Allogenic slit with prolonged systemic immunosuppression has emerged as a very good treatment option, and that should be considered. Thank you.
Thank you. Next presenter, Sohini Mandal. Presenter number 7, Roli Khurana.
A very good afternoon to all of you. So I'll be presenting a rare case of white eye seen in a child because of mumps. So we had a 4-year-old female who had a white eye which was noticed by the mother and not by the patient herself, and it was associated with very mild fornicial redness, and there was no other positive history except that the child had just convalescent from mumps a week back. So the child was not complaining, and this was a problem here because it could have led to some kind of a vision deterioration which we would have not been able to handle later on. So the vision in the left eye was hand movement and PR was accurate, IOP was within normal limits, there was diffuse conjunctival congestion, and there was stromal edema with Descemet membrane folds. AIOS2025 or specular could not be done at this point because at this point the child was symptomatic and slightly uncooperative. So this was a clinical appearance at the initial presentation, and the B scan was done to see that the posterior segment was fine. So in the list of pediatric corneal diseases, we could really point out to viral keratitis. So coming to mumps, it is a paramyxovirus, RNA single-stranded virus with an annual incidence of 100 to 1000 cases in a 100,000 population. Primarily, it causes swelling of the parotids, parotitis, and spreads through lymphoid tissues. And viremia lasts for 10 to 12 days. So in this 10 to 12 days picture, we could see that the eye got affected. So other organs, inflammation of the meninges or the pancreas or the ovaries and the heart can also be seen in deafness. So coming to the ocular manifestations, keratitis alone is like the rarest, as has been reported earlier. The most common is dicryoadenitis and then other inflammation of any other part of the eye. So coming to mumps keratitis, the onset is 2 to 11 days after the onset of the parotid swelling, and it is usually unilateral, as it was in our case, and there's rapid corneal clouding, avascular interstitial keratitis with stromal edema, Descemet folds, and there could be microcystic epithelial edema and associated with iritis. In our case, we did not find any iritis associated. So we just started the patient on prednisolone 1% QID with pressure-lowering medications, that is a timolol, and a sodium chloride drops with cycloplegics. Vision improved rapidly, and the patient quite recovered quickly. And this is a picture that was taken 2 weeks after the treatment. So final outcome at 6 weeks, the patient was back to 6.6, but there was a reduced endothelial cell count. As you can see that the cell density, the variance, all of them have been affected in the left eye. So why are we discussing this case? It is a rare case of isolated keratitis. It is a young child, the youngest ever reported. And the most important is that since 2020, from the universal immunization program, mumps vaccine has now been removed. So there has been a surge of cases that has been seen since then. So this is a rare case, and there have been only this is the 6th reported so far. And there have been 5 cases earlier. The youngest that was reported earlier was around 8 years, and this is the youngest child that we've seen till now. So since it was excluded, there was a sudden surge in cases of mumps, and it was very sad to see that when we asked the patients if she was immunized for mumps, and she told that no, we were not immunized because we were told that we don't need the immunization now, since they were from a government, from a background where there was only government facilities available. So 764 cases of mumps have been reported in 2021 and 22, which was again underreported. Many would not have been followed up. So coming to the conclusion, accurate history and high clinical suspicion should prompt management to reduce endothelial cell function. Had we diagnosed it even later, we would have seen a further or maybe even an irreversible endothelial cell dysfunction. And with the exclusion of MMR vaccine from the UIP, that is the Universal Immunization Program, a surge in the cases of mumps, possibility of ocular complications should always be kept in mind in such cases to avoid such sequelae. Thank you.
Thank you. I request all the presenters to stay back. We will have some Q&A if we have time left in the end. Okay. Next presenter, Mahima Chand.
अरे उसमें है मतलब जो हॉल वाला है
There seems to be a technical error, so we'll come back to Mahima. And is Nidhi Patwardhan here? I don't think she's here. And Arpita Khasnavis, you can present, ma'am. Yeah, Mahima, you do know that you're not a ratified member, so your paper will not be eligible for the competition. You can just present. You can come here. So Arpita Khasnavis.
Good afternoon, everyone. I'm Arpita Khasnavis, and the topic that I would be presenting is coletotrichum keratitis, the clinical features, risk factors, and outcome. So the genus coletotrichum, it's a demeticious fungus of the Coelomycetes group, and it's a plant pathogen known to cause anthracnosis. In humans, they cause subcutaneous and systemic infection as well as keratitis. The Coletotrichum species associated with human ophthalmic infection include Coletotrichum dementium and Coletotrichum cocodes. Early identification, antibiotic susceptibility evaluation, and early initiation of appropriate treatment can help in faster resolution of signs and symptoms and avoid complications like perforation and endophthalmitis. It's a rare case of microbial keratitis, but there are very few case reports and small case series of Coletotrichum that have been reported worldwide. The data regarding clinico-microbiological profile and treatment outcome of Coletotrichum keratitis needs further evaluation. So it was a retrospective study carried out in a tertiary eye care center. Patients diagnosed with culture-proven Coletotrichum keratitis from January 2020 to December 2021 were included in the study, and data collected were demographic details, risk factors, the ulcer characteristics, the visual acuity at the time of presentation and final follow-up, the management, and the final outcome. At the end point of evaluation, we defined our result as complete success when there was complete resolution of the infiltrate with formation of a scar on medical management alone, partial success when there was complete resolution of infiltrate on medical treatment as well as minor surgical treatment like the use of cyanoacrylate glue and bandage contact lens, and the result was declared as failure when there was worsening of the ulcer necessitating therapeutic PK or evisceration. So 49 eyes of 49 patients were included in the study. 55% of the patients had superficial infiltrate at the time of presentation, and 45% patients had deep infiltrate. 67% patients were diagnosed with Coletotrichum cocodes, and 33% had Coletotrichum dementium. At the time of presentation, the group with superficial infiltrate had significantly better visual acuity compared to the group with the denser infiltrate. There was no significant difference in the ocular risk factor or the type of trauma. However, there was significant difference in the duration of symptoms, with patients with dense infiltrate having a longer duration of symptom. Moving on to the ulcer characteristic. Patients with dense infiltrate had a central ulcer, which explained the lower visual acuity at the time of presentation. They had significant thinning, and perforation was noted in almost 14% of the patients at the time of presentation. Moving on to the management part. At the time of presentation, medical treatment was started for 75% of the patients in patchy superficial infiltrate, and 31% received medical management alone in the dense group. In the primary medical therapy, maximum patients were treated with natamycin or combination of natamycin and ketoconazole. Just 5% patient in the denser group received amphotericin with ketoconazole because of the worsening infiltrate. 75% of the patients in the superficial patchy infiltrate group improved on medical management alone, whereas just 18% of the patient with the dense infiltrate improved on medical management, and 83% of the patients required further surgical intervention. After minor surgical intervention, 93% of the patients in the superficial group improved. However, 77% of the patients in the deeper infiltrate group required surgical intervention in the form of therapeutic PK or a tectonic PK. At the final outcome, in the visual acuity, there was significant difference in the visual acuity in the superficial infiltrate group compared to the denser infiltrate group. There was a smaller subgroup of patients in whom susceptibility for various antifungals were carried out. And as we can see, the MIC concentration for ketoconazole and voriconazole was the lowest amongst all the antifungals. However, all our patients were treated with ketoconazole and natamycin. None of the patients were given voriconazole, and they all improved and responded to natamycin and ketoconazole alone. So, but because of a very small sample size, this cannot be extrapolated to a larger population, and a larger study would be required with a larger sample size. To quickly conclude, superficial infiltrate group 93% had good anatomical outcome, with 75% patients having primary success, 18.5% with partial success, and failure noted in 7.4% of the patients. In the deeper infiltrate group, 13% patients had primary success, 4.5% had secondary success, and 81% had failure. So it's Coletotrichum keratitis, often linked to trauma, has better outcome with early treatment. The dense infiltrate and delayed presentation often necessitate more invasive procedures and result in poorer outcomes. Thank you.
Thank you. Diksha Sharma is here.
Good afternoon, everyone. I will be presenting the comparison of pachymetry using anterior segment OCT and ultrasound biomicroscopy in congenital corneal opacities. As we all know, the congenital corneal opacities are etiologically heterogeneous group of disorder with challenging diagnosis and treatment. And early visual deprivation frequently result in severe sensory deprivation amblyopia in these kids. So measurement of central corneal thickness play an important role in both diagnostic and therapeutic assessments of ocular diseases. There are various tools which are used to measure the central corneal thickness like ultrasound, biomicroscopy, ultrasound pachymetry and OCT. But an ideal tool should be accurate, reliable, safe and non-invasive. So coming on to the ultrasound pachymetry, it's basically used as a standard in measuring the corneal thickness, and it's a contact procedure, and the perpendicularity of the probe with respect to the cornea is very important. But sometimes in dense corneal opacities, it could not capture the central corneal thickness. So ultrasound biomicroscopy, it's high resolution, high frequency and real time, and it's used to visualize the anterior segment in corneal opacities also. Anterior segment optical coherence tomography is non-invasive, non-contact and fast method, and it has role in diagnostic and pre-operative evaluation of the anterior segment diseases also, and it has better resolution than the UBM. So in this study, our objective was to determine the interchangeability of the pachymetry measured by AIOS2025 and UBM in congenital corneal opacities. So it was a comparative consecutive case series which was done from January 2022 to January 2024. And all children below 5 years of age with unilateral or bilateral congenital corneal opacities were included in this study. All the children underwent examination under anesthesia and anterior segment OCT during the routine OPD visits. And outcome measures were comparability of the corneal thickness measured using AIOS2025 and UBM, and to assess the interchangeability of both the devices. So it's a short video how the ACCT was captured using AIOS2025. In this, the child was, after applying the speculum, the child was the AIOS2025 was captured whenever the child fixates, because it take images in very short time. So pachymetry measured was horizontal images were selected to measure the pachymetry in both the devices from UBM and the AIOS2025, and the inbuilt caliper in AIOS2025 and UBM were used to measure the central corneal thickness in both the modalities. And in the AIOS2025, the central location is based on the scleral spur to scleral spur diameter, and the same location on the UBM image was used to measure the central corneal thickness. So in results, coming on to the results, the 54 eyes of 36 patients were imaged with both UBM and AIOS2025, and the mean pachymetry measured with the UBM was 844, and with AIOS2025 it was 675. On Pearson's correlation, there was a significant correlation between the two CCTs on two-tailed test, but AIOS2025 was consistently underestimating the central corneal thickness values, and on Bland-Altman plot there was lack of agreement between the two modalities. So we concluded that AIOS2025 and UBM correlate well in the majority of the cases, but the pachymetry values are not interchangeable, and UBM is still the modality of choice as it penetrates better in cases with the retrocorneal membranes and dense lenticular adhesions. So limitation of the study was lack of control group, small sample size, and lack of centration while doing the UBM and AIOS2025. And there can be observer bias due to the manual measurements. Thank you.
Thank you. We'll come to the final presenter, Dr. Aishwarya K.
Good afternoon. I'll be presenting on analysis of ocular surface and corneal changes in type 2 diabetes mellitus patients. It's a descriptive cross-sectional study. So diabetes mellitus causes ocular complications. We all know it's diabetic retinopathy, papillopathy, and it also has a good effect on ocular surface. So there is deposition of glycation products at the basement membrane, which leads to the epitheliopathy. So our aim was to assess the effects of type 2 diabetes mellitus on morphological parameters of the corneal endothelium, CCT, and tear function. So it's a descriptive cross-section study conducted for 2 years. And all type 2 diabetes mellitus patients above the age of 18 years were included, and any history of previous ocular surgery or corneal disease or dystrophy or any active inflammation, glaucoma or use of contact lenses, these patients were excluded. So all type 2 diabetes mellitus patients visiting our center were enrolled, and after collecting the demographic details, duration of diabetes mellitus HbA1c status were noted, and they were presented with the ocular surface disease index questionnaire, and a score out of 100 was obtained. And also visual acuity by Snellen chart, IOP, and examination of lens. Meibomian gland dysfunction also was examined, and tear meniscus height, Schirmer's tear wake-up time, Van Dissewald score for grading the staining of cornea and conjunctiva, followed by fundus examination for the diabetic retinopathy severity. So a total of 100 patients were included, and the mean duration of diabetes was 9.4 years, and HbA1c was at around 8.38. And coming to the association of severity of NPDR, with increase in severity of NPDR, the ocular surface disease index score, it increased, and there was decrease in Schirmer's test, tear breakup time, and hexagonal cell ratio, and they were all statistically significant. And comparing the HbA1c, as HbA1c increased, there was decrease in tear breakup time and increase in OSDI score. So here we can see the association of severity of diabetic retinopathy with the OSDI, it increased with the severity, and Schirmer's decreased with severity, and also with increase in HbA1c, Schirmer's test decreased, and there was a more severe meibomian gland dysfunction. So with the increase in severity of diabetic retinopathy, we noted that there was an increase in OSDI score, Schirmer's test value decreased T-BUT, and Van Dissewald score increased, and also there was a significant decrease in hexagonal cell ratio obtained by the specular microscopy. And with the increase in duration of diabetes, there was decreased corneal sensation and increase in Van Dissewald score, indicating the severity of dry eye. And with increase in HbA1c, decrease in Schirmer's test value, and all these parameters like T-BUT, tear meniscus height, and OSDI were obtained, which indicated increase in severity of dry eye. So previous studies have been done which showed association of dry eye with diabetes mellitus, and also the dry eye risk increases with the presence of diabetic retinopathy, and also the hexagonal cell ratio and endothelial cell density were found to be decreased with the severity of diabetic retinopathy. So these studies also noted a increase in OSDI and decrease in T-BUT with the severity of diabetic retinopathy. So I would like to conclude that there is an increase in severity of dry eye with an increase in the duration of diabetes mellitus and long-standing hyperglycemia and a severity of diabetic retinopathy. So with the severity of diabetic retinopathy, all patients need to be screened for this corneal epitheliopathy for a better treatment benefit. Thank you.
Thank you. Any questions for the last presenter?
So did you notice any level of HbA1c or after which we should definitely screen for these dry eye patients?
Sir, beyond 8, there was increase in severity of
Significant
diabetes.
findings.
Yes, sir.
Okay. And any specific type of dry eye you found in these patients, evaporative or aqueous deficient?
There was more of meibomian gland dysfunction.
MGDs.
Yes, sir.
And any specific correlation with any anti-diabetic medications with the dry eye?
Sir, what we noted was patient taking insulin had more, that more correlates with the severity of
That's the severity,
sugar
but,
control.
but most of these patients are on anti-diabetic medications. So have you noted any medication that correlates every time with the severe findings
No,
of
sir,
dry eye?
no difference
not
between the
really.
OHs.
Okay, thank you.
I have a question for the first presenter,
Thank you.
Mrinalini. So in your femtosecond FAL group, you didn't tell us about the parameters that you use for your femtosecond cut. Was there a disparity between the recipient and the donor?
So recipient and the donor size in the
Yes.
diameters, they were same.
Exact
around
same.
The range of, yes, sir, same diameters in the range of 7.9 to 8.5.
Okay, so you didn't have any patients who had like an override, or
No, sir.
was it a perfect fit?
No, yes, sir. They were
Okay.
same in diameter.
And the depth calculation, you varied it depending on the opacity?
Yes, sir.
So
According
how
to
deep, what is the maximum depth that you went?
Sir, all were less than 200.
All were less than 200.
Yes, sir, less than 200.
And the microkeratome was a fixed depth.
Yes, sir, but our criteria was less than 200. So in the microkeratome group also we have included superficial opacities only.
So 150 microns, what was the
Sir,
head size?
Yes, sir, 150 for microkeratome.
Yes,
Yes.
okay.
Sir, just one comment. So, do you find any problem with femtosecond cuts in scarred corneas?
No, sir, as such we have not.
Because
encountered
femtosecond
any.
doesn't work very well in scarred corneas, and most of SALC patients have a scar only. So, no
Sir,
problem in cutting the patient's cornea.
No, sir, there were no problems encountered
Okay.
otherwise.
I have one more question for Sohini Mandal. Sorry, yeah, not Sohini. For Roli Kurana. So you said that it was interstitial keratitis following mumps.
Yes.
On what basis did you make the diagnosis of
Sir,
interstitial?
endothelitis.
Yeah, endothelitis I agree, but you mentioned interstitial keratitis in your presentation.
Sir.
So on what basis did you make that diagnosis?
No, sir, endothelitis.
Yeah, so it is wrongly mentioned in your slide.
Sorry.
Any other questions? Dr. Mahima, so in your series, you've not presented, no? You're here to present, yeah. So please come and present your microbial keratitis, microbiological profile, and assessing topical efficacy of topical insulin as an adjuvant.
Good afternoon, sir.
This paper will not be scored because you're not a ratified member.
So as we know that microbial keratitis is a potentially blinding condition, and it is diagnosed by the presence of corneal ulceration with stromal infiltration, hypopyon, anterior chamber reaction, and signs of conjunctival congestion. It depends on the corneal defense mechanism, and the severity of the disease depend on the strain of the organism, size of the inoculum. So the microbiological profile is important. This is a prospective interventional study from period April 24 to August 2024. It included patients with severe keratitis of 10 to 70 years, and for patients who were getting the primary treatment were also included, and the exclusion criteria was herpetic infection, neurotrophic ulcers, keratitis linked to autoimmune disease, and which were during the healing stages. So the patient with the microbial keratitis, corneal scraper taken from 15 number blade or chimera speculum, and then the direct microscopy and culture was done using the gram staining potassium hydroxide, and it was cultured on sheep blood agar and the sabrods dextrose agar. As we can see, there are positivity was seen of the gram stain can be seen, and the sabros. Insulin eye drop, which was instilled in the patient as an adjuvant eye drop along with antimicrobial and drugs. The patients were 6 hourly, it was given to the patients, and the concentration of 1 international unit per ml was used in the regular insulin. In 100 international unit was diluted by using the polyethylene glycol and propylene glycol base. The biological profile keratitis cases were in around 10.5% cases mixed infection was seen, and 23.5% bacterial keratitis, and in around 65.9% cases fungal keratitis. So bacteria species predominantly was found to be Staphylococcus, whereas the fungal Fusarium. So we can see the result mostly the patient who responded to the treatment with the insulin eye drop were the anterior involvement of anterior epithelium, which were the size of the ulcer was less than 5 millimeter into. So the mean healing time was seen around 2.27 weeks, and the visual acuity was also improved around in 52.44% of one line, and in 2 line 32.12% patients, and no improvement in 15.44%. So the ocular trauma was most common predisposing factor for in around 68% cases, where the vegetative matter, dust, and the sand were also common traumatic in fungal keratitis. Most patients had delayed presentation, around 63% after 2 weeks. Previous studies like Wang et al. Did his study on the corneal ulcers that were treated with the topical insulin, and AIOS et al., who 21% with persistent corneal ulcer refractory to the conventional treatment, in which the reepithelialization was seen in around 81% patients. So the conclusion is that the majority of the cases which were involved were from rural areas with agricultural backgrounds, and that insulin eye drops were helpful in cases of post-infective keratitis epithelial defect, which promoted epithelium healing and improves the visual outcomes in superficial ulcers of size less than 5 mm. Thank you.
Thank you. There's only one contradiction in your presentation. In fungal keratitis, we want better penetration, so we sometimes actually remove the epithelium.
Yes, sir.
And you're trying to heal the epithelium. So
after the scraping was done for the microbiological profile, then the treatment was started, and we were doing the scraping regularly for the.
What does literature say about
so in literature,
insulin in keratitis?
Topical insulin has been used for the neurotrophic keratitis, and in the persistent epithelial defect and diabetic keratopathy, where there is requires the involvement of the growth of the nerves. And so in this also we can see the epithelialization is important after the after the healing of the ulcer. So after brief period of time after the treatment, there is delay in the epithelialization due to the involvement of the nerves in all the cases like fungal and bacterial. So it is important for the growth of epithelium. Insulin eye drops were instilled.
Thank you.
Thank you.
thank you. I just have one final question for Dr. Diksha Sharma. You used, is Dr. Diksha? Yeah. So you had used the AIOS2025 for pediatric cases, but you didn't mention of how many cases you had to abandon because the child couldn't really be imaged, or how long the time it took in terms of for imaging a child, because obviously they'll be moving their face and eye. Then you won't get it. Yeah. Thank you. Yeah.
The interstitial keratitis, as in the discussion, it was not for my case. In my case, diagnosis was only endothelial. Thank you, sir.
Thank you. Thank you, everyone. So that kind of concludes. Any comments from the other judges? Any questions? Yeah.
Even though there was initial hiccup, I think we had a good audience and a great audience. Thank you.
Thank you. Thank you to all the presenters. Very nice presentations. And the scores will be sent to the scientific committee. Thank you.
Some mistake. Your mark here half there.